Good evening, everyone. We are so excited to see you. Hello, 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 hello. Once again, we are incredibly thrilled to see you. Today is such an important day as we kick off our 2023 Black Maternal Health Week. I am Dr. Valencia Walker, and I'm a neonatologist. So hopefully that might be a little obvious as to why I care about Black Maternal Health Week. And what I usually tell people as a neonatologist, I take care of any baby that needs to be in the intensive care unit, and including the babies when they're first born if they have any difficulties. And I remind people that I love all things cute pink baby toes. And the one thing that I know for sure that makes a difference in the lives of my patients, my little babies, is when they have healthy mamas. And so in addition to being a clinician, I'm also the Vice Dean for Health Equity and Inclusion at Geisinger Commonwealth School of Medicine. This is not an endorsement of my institution or affiliation. But in addition to that, what I'm most proud of is my role as chair for the board of Birthing the Magic. And this is kicking off an amazing week that we get to share with you with people from all over the country. And I want to be clear with you. We're going to give you the experts, but we're going to give you experts that look like me and probably look a lot like you. And we aren't just doing this because it's a paycheck. We're not just doing this because, we spent a lot of money going to school and stayed up a lot of long nights. We're doing this because we come from a place of love and caring. And we know the statistics. We know all the things that keep you up at night and that you worry about. And we want you to be empowered. We want you to know the truth. We want you to know how to talk the talk when you're in a room, maybe with someone who may not look like me or may not look like you. And so with that, I have the incredible honor of introducing our very first speaker for the evening. And I promise you that I practiced, but I think I still need a little more practice. So Dr. Cynthia, please correct me. But we have with us this evening Dr. Cynthia Gyamfi-Bannerman, who is the chair of obstetrics, gynecology, and reproductive services at University of California, San Diego School of Medicine. She is all the qualifications and all the Black girl magic. She is board certified in obstetrics and gynecology. She's also board certified in maternal fetal medicine. Y'all know if we don't do anything else, we get all the degrees and all the credentials so that you can't question how we show up in these spaces. But what I am so excited about in listening to her tonight is that she does incredible work that's focused on preventing babies from being born prematurely. Now that may seem odd. That's what I do for a living. But I truly believe my job is to put myself out of business. And with the work that she does to prevent premature births and preterm births, she's done a lot of work that has led to research and science and understanding and 200 peer-reviewed publications. The other thing you need to know about me, I am a total nerd. And when it comes to doing the science, and when I say all the credentials, when you have all your peers that look for reasons for you to be wrong and you prove them wrong and put the truth out there anyway, that is impressive. And that is what she's done with her career. So of course, she was elected to the American Society of Clinical Investigation. And not only that, really being a change maker and a leader, she is both a board member and president-elect of the Society for Maternal Fetal Medicine. Today, she's going to talk to us about something called preeclampsia. You've probably heard the word. You may have even heard of something called toxemia. She's going to tell you what it is, what it isn't, and why it matters for your health, for my health, and of course, for those cute little pink baby toes that I love so much as well. So I would like to turn it over to you. Thank you so much for being here.
Thank you so much, Dr. Walker. I'm so humbled by that introduction. It's so lovely and so kind, and I really appreciate it. And thanks to all of you who have joined this evening. It's still afternoon in California where I am. I'm at UC San Diego. And it's if you're in the South California area, it's a great place to come and have a baby. So I have the honor and pleasure of speaking to you all about preeclampsia. And so what I'm going to do, I have just a few slides so that we can all level set and be on the same page about what preeclampsia is. And then we'll move forward with a dialogue where we can have a question and answer, and hopefully we can answer all of your questions about the topic by the end of the evening. So let me quickly share my screen. Okay. All right, does everybody see those slides? Perfect, okay. So the first thing I'm going to talk to you all about is what exactly is preeclampsia? So important for you all to know, it is more than just high blood pressure. We all know people who have high blood pressure, and so sometimes it's difficult for us to understand what the differences are between just having high blood pressure and having something called preeclampsia. So while high blood pressure is one of the signs of preeclampsia, preeclampsia is more than high blood pressure. So that's one thing I want you all to remember by the end of this. It's very specific to pregnancy. But I've also listed here that it also occurs in the postpartum period. And I think one of the problems in the way that we defined preeclampsia previously was that most folks thought it was only pregnancy related and that you couldn't have it postpartum, but you still can. So that's really important to know because we see a lot of people getting sick right after they deliver, and you can still have preeclampsia at that point. So by definition, preeclampsia happens after 20 weeks of pregnancy. So if you have high blood pressure when you go into your doctor's office at the first visit and you're in the first trimester, this is not preeclampsia. This is probably a diagnosis of chronic hypertension. And that makes a difference in the way you're managed. So important to know, but usually it doesn't happen at all before 20 weeks. And it usually happens at term. It can involve your kidneys, your liver, and your brain in a very rapid fashion and in a way that you wouldn't expect if you just had high blood pressure. It can be very slow or very quick, and we as doctors and obstetricians and midwives and anyone who takes care of an obstetric patient doesn't really know which version of preeclampsia you're going to get if you happen to get preeclampsia. So it can be very slow, or it can be very, very fast. And it's very common. So it happens in about 5 to 10% of all pregnancies. And so I can tell you that every single day on our labor floor, we'll have at least 1 or 2 patients that have preeclampsia. So it's something that we see all of the time. So this graphic depicts when preeclampsia occurs. And like Dr. Walker mentioned to you all, it is very important to kind of speak the same language as the folks who are taking care of you. And so while people think of pregnancy as being 9 months, most obstetric providers will tell you that pregnancy is 40 weeks because that is a little bit longer than 9 months. They don't correlate well, which is why we tend to speak in weeks rather than months. So if 40 weeks is a typical pregnancy, then your risk for getting preeclampsia starts here at about 20 weeks and goes until you're about 6 weeks postpartum. But important for you guys to know, really the majority of preeclampsia happens right in this little box right here. So near term and near the first couple of weeks after you deliver. Very unlikely to happen before that and a little bit unusual to happen after that as well. So what are the signs? We talked about blood pressure. So these are just the numbers for you to know in case you're pregnant now or have a family member who's telling you that they have blood pressures this high. If your blood pressure is elevated to 140 on the systolic side or the top number, or greater than 90 on the bottom number, then that should be concerning to you and your doctor. And then there's some symptoms. So there's headache, there's some visual changes, which we call scotoma, and there's epigastric pain. The epigastrum is right under your chest or the top of your belly. Important again to know, most people who have preeclampsia don't have any of those symptoms. But if you have those symptoms and you're pregnant and you're in the second half of your pregnancy, this is something you should tell your OB provider immediately because those are concerning. And then there's swelling. So people talk about swelling, and maybe about 30 or 40 years ago, swelling was one of the criteria. It's been removed because I would say 50% of pregnant women have some element of swelling. But what's important for folks to know is that if you suddenly wake up from not having any swelling and suddenly are extremely swollen, that's concerning, and you should probably alert your OB provider again because that's very unusual. So even though swelling in and of itself is not a sign of preeclampsia, sudden swelling that's extreme and has gone to your hands and your face is something to pay attention to. And when you have any of these symptoms and you haven't checked your blood pressure, it would be a good idea to check your blood pressure if you have a cuff at home, or if you have access to a cuff, or even if you see your doctor for that. All right, so who is at risk? So we have what we call high risk criteria, and then we have moderate risk criteria for preeclampsia. So these listed here are the high risk criteria. So if you're pregnant with twins, or you have pre-existing diabetes, you have high blood pressure, pre-existing again, you have some type of kidney disease, you have connective tissue disease, and lupus would be the most common of those. Or if you've had preeclampsia before, then you're considered high risk to have preeclampsia again. But there are also moderate risk factors, and you have to have more than one of these. So if you have a high risk factor, you're already considered high risk. If you have one of these, then you have to have at least 2 of them to be considered higher risk for preeclampsia. So if you're 35 or older, someone in your family's had preeclampsia, your sister, your mom. If this is your first pregnancy, that puts you at risk for preeclampsia. If you're obese, that puts you at risk. If you've had a history of having a small baby, some poor pregnancy outcome, or it's been at least 10 years since your last pregnancy, then that puts you at risk. And so the next bullet, Black race, is very interesting because even 4 or 5 years ago, I don't think it was recognized that Black race was a risk factor for preeclampsia for reasons other than the race itself. I think what everyone is beginning to understand now, which is really important for all of us, is that Black race is just a proxy for racism, and it's not something that is inherent to race itself. And in fact, the guidelines specifically say Black race as a proxy for racism. So I'm writing them down directly from the guidelines that are out for all OBGYN providers. And then last is IVF pregnancy. So looking at this list, it's very easy for many people to have more than one of this. If you're 35 and it's your first pregnancy, then you're at high risk for preeclampsia. Or you're Black and it's your first pregnancy, that puts you at high risk for preeclampsia. These criteria are actually listed out for people who practice obstetrics to know that they should really identify these people as high risk for preeclampsia and offer them prevention. So how do you prevent preeclampsia? So prevention means that you lower your risk. It doesn't take it completely away, as you all know, but this is something that you can do to help yourself have a lower risk of preeclampsia, and it's a baby aspirin. So it's pretty easy. We call it a baby aspirin because it's a fraction of the dose. A regular aspirin is 325 milligrams, and a baby aspirin is just 81 milligrams. So that's why it's called a baby aspirin. It has nothing to do with actual babies. But if you start a baby aspirin at 12 weeks and continue it throughout the pregnancy, then that lowers your risk for preeclampsia. And I've listed all those risk factors for you, so you can talk to your doctor or midwife about, should you be on it? Are you on it? And what are the risk factors? I actually put here the ACOG committee opinion. ACOG stands for American College of Obstetricians and Gynecologists, and that body writes all of the opinions on practice in obstetrics. And I show you this because I was one of the authors of this committee opinion. And so not only do I practice this, and this is considered practice around the country, and actually we're developing standards and metrics to make sure that people who should be on aspirin are on aspirin. But I'm telling you this so that you know that I feel pretty strongly that this is going to be really important for a lot of people who are at risk. So how can you treat preeclampsia? So that is it's a really important question, because the answer is we don't really have a treatment. Once you have preeclampsia, it doesn't go away unless you get delivered. And I should have put an asterisk or a caveat to that, because it's not that it goes away with delivery. There is some risk of having residual new preeclampsia after you deliver, but that the further you are away from delivery, the lower the chances that you'll get preeclampsia again. Some patients have very mild disease, what's called technically preeclampsia without severe features, and this can be watched. And then if it gets worse, then you might be recommended to have delivery. Some have severe disease right away, or might need to be monitored as an inpatient, or might even need a preterm delivery. And again, we can't really tell right away which type someone is going to have. Importantly, it's very important to be monitored closely. If you have been told that you have preeclampsia and then you're not getting monitored closely by your provider, then that's something that you should talk to them about. So what happens if it's missed or it's untreated? Well, unfortunately, that's something that, we've seen, and we've seen very horrible outcomes from either missed or untreated preeclampsia. Untreated meaning undelivered when delivery was indicated, because it isn't always. But the patient can get very sick. You can get seizures, which is called eclampsia. You can develop HELP syndrome, which is an acronym, and that's listed there, but that's also a bad form of preeclampsia. And it can affect your liver and kidneys in a very bad way. Rarely, but possibly, it can lead to stroke. It can cause maternal death, or it can cause the baby to die. And it still is listed in the top 5 causes of maternal death around the world. So important to know and recognize, but also know that it's very common and very, 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 very manageable and treatable. So what happens if you've had preeclampsia in the past? So you had a pregnancy, you had preeclampsia, you got delivered, and everything went well. You are at higher risk for heart disease down the line, maybe in 5 to 10 years. So it's a matter of having close follow-up with your primary care doctor. One thing that we're trying to do is inform your internal medicine doc or your family medicine doc about what the risks look like for a woman who's had preeclampsia, because sometimes that history isn't always communicated to the doctor who's not an obstetrician, or maybe they just don't even realize that that would put you at risk. And so in the medical world, we're trying to train some of the other doctors who are outside of our field to recognize that someone who's had preeclampsia is at high risk. Similarly, we're trying to train emergency room doctors to recognize that if someone comes in with a blood pressure of 140/90, you need to get a history of if they're postpartum, because they could be at risk for preeclampsia in a way that someone who's not postpartum wouldn't have that risk. So anyways, if you had preeclampsia in the past, follow up with your primary care doc, and then relate that history to them. So this is my last slide, but most people who have preeclampsia will do extremely well. And that's what I want you all to know, because it's so common and most people do very, very well. Close follow-up is going to be incredibly important. And early delivery is sometimes very important to protect both the mom and the baby. But just keep in the back of your minds that it is a leading cause of maternal mortality. And so it's something we take very, very seriously. And hopefully I'll be able to answer all of your questions about this as we move into the question and answer phase. So thank you so much for paying attention to these slides, and I look forward to your questions.
Awesome. So we got a few questions in advance, and I'd like to start with those, and then we'll kind of open it up and people can type into the chat. I'm sorry, either into the chat or into the Q&A button if they have other questions. There is one question in the Q&A that I'd like to acknowledge. And so some people are interested, I think they're kind of nerdy like me, and wanted to know if your slides would be available to share with people.
I would be happy to share those slides, absolutely.
Yeah. Okay, awesome. Well, one of the questions I'd like to ask is, you said preeclampsia happens around 20 weeks. That's kind of typical. You made a point of kind of showing how it can be different from like high blood pressure. We hear a lot though about changing our diet or changing our lifestyle. Are there things you recommend or things you can do in terms of your diet or your lifestyle to affect how your body, develops preeclampsia, or to protect yourself from preeclampsia?
So I would say before pregnancy, noting what the risk factors are. There's some that potentially could be mitigated. For instance, obesity, there's not too much else that can be mitigated there. And so there's not so much that you can do aside from, living a healthy lifestyle, getting early prenatal care, that can help. But usually, for women who are at risk for preeclampsia, it doesn't usually happen at 20 weeks. That's the earliest it can happen. So most people will not get preeclampsia until their term. But so before that, if you're diagnosed with high blood pressure or chronic hypertension, diet, exercise, all of those things work for chronic hypertension in a way that they are not going to work for preeclampsia. Preeclampsia is a different animal. So changing your diet or doing that once you have the diagnosis is not going to be helpful.
So this is where I'm going to put myself out there, right? Like, I'm a whole doctor and I actually work with OBs all the time, but we still have big differences in what we do. When I think about preeclampsia, I think of the blood vessels and the placenta kind of going the wrong way and kind of triggering signals, and your body's like, blood pressure goes up. And like you said, we can have bad reactions to that. Is that a fair way of kind of understanding why, you can't diet your way out of it, or, things like that?
Yeah, no, that's absolutely true. In fact, while we know that it happens at the time that there's implantation, so it happens around the first trimester, but we won't see it clinically until much later on. So yeah, it's something that's happened early on, and it's something that will manifest later, but it happened so early that there's no diet or exercise that would change it at that point.
So it's kind of similar to hypertension. We talk about it being a silent killer, like it's something that's happening, but you can't like feel it or touch it or things like that until you start to see the signs.
Yeah.
Okay. So another question though related to that, someone had asked in advance, is this genetic? Like my sister had preeclampsia. Am I at increased risk for having preeclampsia?
So yes, there's a strong family history will put you at a higher risk for preeclampsia. And there are some genes related to preeclampsia, but I think that the majority of this is not going to be genetically driven. But yes, there's a family history component, absolutely.
So it is helpful to at least know like your family history, because that can help kind of prepare you and know what to expect. And you can have that conversation with the people that are taking care of you.
Yeah, and if they don't ask, it's something that you can offer, and a lot of times I've noticed when I see patients for the first time, who are also pregnant for the first time, it's that time to ask your family, what is the history? Because sometimes you learn things that you never learned, and it's your first pregnancy. And so it's nice to just check with your mom, check with your family members, and see how their pregnancies went. And I'm sure someone's going to have a great story for you about how their pregnancy went and their experience.
I think that is such an important point. Often the same for us. We'll talk to someone and be like, oh, has anyone else in your family had a premature baby? Or did anyone else have a baby that had this problem? And then they start talking to people, and it's like, now we're going to have that conversation at some point this week. We got to start talking to each other about what's really happening and what we really experience and what we go through to help each other. I will say, I am happy to report people have been listening, and I bet if we could see them, I think they are like taking notes and everything. One question that came up, which I think is a great question, my bias, any side effects of baby aspirin on the fetus, the baby that's growing inside of you?
Not that we know of. And we've been studying this specific to pregnancy for probably about 40 years, close to 40 years. So yeah, no side effects.
So that's a medication that can help prevent some of the complications of preeclampsia. And it doesn't seem to cause any harm to the baby from all the research that we have so far.
Yeah.
Okay. Again, people are really listening to you. So another question that came up. So this is someone who we want you to be the model patient that we take with you everywhere we go. So this person says, I check my blood pressure daily. Y'all, the way we beg people to do that and no one actually does it. So that's awesome. If you can't tell, I'm from the South. So the question is, should you be alerting your doctor if either the systolic, which is that first number of your blood pressure, or the diastolic, which is the second number or the bottom number, if the first number is over 140, or the second number is over 90, or do you wait until both numbers are high?
Great question. So alert, if either number is high, you don't need to wait for both numbers. One thing to keep in mind is that your blood pressure cuff at home and the blood pressure reading in the office might be different. So if you've been instructed to check your pressure, or if you decided to check your pressure, either way, just bring in your cuff to the office so they can be compared, so that you can see if your cuff is running high or running low, and what the differences are. Because sometimes it's going to be different information, and so you want to know, and maybe you need a different type of cuff, or maybe you just know that your numbers are running higher than the office or lower than the office. But those are really important things to figure out. And then it also, there's a variety of different ways to approach this. Certainly, if you're worried about preeclampsia or you have a strong family history, then I would allow yourself to kind of maybe enjoy the first 20 weeks of your pregnancy, because you can't get preeclampsia then. And then if you wanted to check your blood pressure more frequently in the second half, absolutely you can do that. Some people get anxious, and so the process of checking all the time creates more anxiety. But it's always a good idea.
Your blood pressure goes up.
Exactly. But it's always a good idea to know like what you generally run. And so having that cuff and getting that information for yourself is really helpful, and really helpful to inform your care provider.
Now, for people who may not have like a blood pressure cuff at home, right? Like let's be practical. What happens if you like just go into like the Walgreens or something like that and take your blood pressure there? Like, do you have any recommendations on that? I know that's not quite OB, but just thinking
No,
about
absolutely. Yeah. I mean, a lot of our patients have done that, because I mean, I've been doing this, I guess, for 20 years before everybody had a blood pressure cuff, right? And we actually used to tell patients, why don't you just go to Walgreens and check your blood pressure? So those things are important to do. But I think most importantly, when you really want to check your blood pressure is when you have a headache and it hasn't gone away. So if you have a headache, what we're going to tell you is please take Tylenol. And it's not because we want you to feel better. Of course, we want you to feel better, but if you have a preeclampsia headache, it won't go away with Tylenol. So the very first thing that we would ask you to do, either, as an outpatient or once you come to the hospital, is please take Tylenol so we can see if this goes away. If it doesn't go away, we're very concerned that this might be a preeclamptic headache. So if you have a headache and you happen to be in the second half of your pregnancy, one of the first things you want to do is check your blood pressure and just kind of make sure to see where you are, report this to the people taking care of you. But those are times where if you didn't have access to a cuff and you didn't want to go into Walgreens every day, that would be the time to go to Walgreens. Or if you started to see floaters in your vision, or something was different, obviously you can also go to your doctor at that point, but sometimes it's easier just to stop by the local store and see what's going on.
Okay, so then the next question is going back to this idea of aspirin, right? Like I can just take this little pill, and one person is saying, my doctor recommends one baby aspirin on the even days and two baby aspirins on the odd days. Have you heard of that regimen? And at least for you and your recommendations, is that something that you advise?
It's a very funny question, because today I submitted a grant to the NIH to study that question, because we actually don't have the answer to it. And so what they're doing is they're taking data from Europe. Europe doesn't have the same aspirin formulation that we do. They have different antiplatelet agents, and they've studied 150 milligrams, which is considered a low dose of aspirin, and have different outcomes using different screening. And so it's hard to extrapolate that to a US population. And so people argue, should you do 81 or should you do 162? And this is getting very geeky and scientific, but we don't have an answer. And the recommendation as listed is 81. We know that some women have aspirin resistance, and whether the aspirin resistance is influencing the outcome is something that we're actually just submitting this grant to study. So we don't know that answer yet, but so there's some people who strongly feel that a higher dose is better, but the recommendation is 81, and that's what there's consensus around.
Okay, so kind of standard is 81. There's a lot of research on that. There are questions, and we still have to try to figure that out.
Yeah.
I'm going to pause for editorial. And I love the way that you answered that question, because you were like, we don't know. And we've been doing medicine, as in the field of medicine, for a long time. And these types of questions, you would think doctors would know the answer to, but we don't know. And I think it's important for us to be honest about that, but also to say like why we do the research and why it's important to participate in research. Because at the end of the day, right, we want to make sure that our patients get the best possible care. And at least for me, I'm always learning something new, and I'm always figuring out how to take better care of my patients. I think that is what makes good science and good medicine.
Oh, absolutely. Because, the knee jerk would be, well, one is good, two must be better, but two might have more side effects and more complications, and we don't know that yet. So that's why it has to be studied kind of rigorously. Most of the literature on aspirin is looking at doses that are either 60, 81, 100, and 150, and really not more than that. And so it's hard to say.
And I think for a while, there took a while even to get consensus that like 81 was safe. Like
Yeah.
people had started doing it, but we were waiting on more research. So this is always like evolving knowledge. And we get to have these conversations so people do, like you said, know what to tell their doctors about their family history and what to ask their doctors as well. So I guess for that person, if that's what your doctor recommended, you're following up, you're monitoring for side effects, then as long as you have that monitoring, that's probably what's most important right now.
Yeah, yeah. I think if you see that you met the criteria and you're not on aspirin, that's, have a conversation with the person taking care of you to say, um, I think I might meet some criteria for aspirin. What do you think? You can point them to the ACOG document, which is guides the standard of care in obstetrics. And you should have a conversation about it because it's a pretty simple thing that folks can do to decrease their risk. And, when we see people who come in with bad preeclampsia who met the criteria, it's always sad because like they could have had a baby aspirin, and not that it's curative in any way, but it does decrease the likelihood. It might make it that you get preeclampsia much later, which we just deliver you, and then there's very little sequelae aside from, your future cardiovascular health. But yeah, it's always sad not to be able to treat someone when we have obvious, risk factors listed and a pretty innocuous treatment.
So we're pretty good at what we do as neonatologists, but I will tell you, we would rather take care of a 34-week baby that's born 6 weeks premature versus taking care of a 24-week baby that's born, 4 months premature. So there's definitely a difference if you can mitigate, prevent those severe symptoms of preeclampsia. Now, I am here for the really nerdy people that are on this webinar. So another great question we got, do you know why IVF causes preeclampsia? Or maybe if it doesn't cause it, is associated, or there seems to be a higher incidence of preeclampsia for pregnancies that are a result of in vitro fertilization?
Now, it's a great question, and we don't know the actual answer, but we have theories. And so the process of implantation in an IVF pregnancy is not the same as the process of implantation in a spontaneous pregnancy. So in an IVF pregnancy, the implantation kind of happens for you. And in a spontaneous pregnancy, it happens in a different way. And so there probably is something through the way that the placenta implants initially, because as Dr. Walker mentioned, there's some issues with the way the blood vessels enter, and that's probably related to why there's more preeclampsia in IVF pregnancies. But it's challenging to say. They have looked at as age as a factor, but it looks like IVF independently is a risk factor and not just being older and having IVF.
Yeah. I'm really impressed with all the questions around the aspirin, and I'm glad that this is an area that you study. So another question that came up, so you mentioned 1 is good, 2 might be too much, we don't know yet. What might be issues with starting aspirin before 12 weeks? Would there be any concern for the fetus or any higher risk of complications?
Fantastic question. Very impressed by the audience. So I struggled with this actually as one of the authors of the guidelines, because when you think about the implantation question, it almost seems too late to wait until 12 weeks to start the medication. There are several large studies now, particularly one that tested almost 12,000 women around the world and gave them baby aspirin, and they started around 10 weeks. And so we know in terms of the safety profile from that point, we're pretty confident. And there's several women who are on baby aspirin even earlier than that because of other medical problems for which they need to be on aspirin. And so for many reasons, I feel comfortable having someone start aspirin before 12 weeks. However, there was one small paper that came out years and years ago that associated earlier start of aspirin with a higher risk of something called gastroschisis, where the intestines come outside of the abdomen and stay outside. It was one paper. Yeah, for the baby. It was one paper. It was a very small increased risk, and we couldn't there was nothing else out there at the time to say that we could safely recommend starting before 12 weeks. We have now a lot of data, so I do think that probably in the next iteration of the recommendation, it might change. But that was the reason that we didn't start, not for any other reason.
And so the gastroschisis, those are the patients that I take care of, right? And so for people who may not be familiar, the way that you described it, the development of a fetus is phenomenal and incredible and fascinating. One of the things that's particularly fascinating is that your intestines leave your body while you're inside of the womb and kind of twist around the way they're supposed to and go back inside of your body before you're born. But in the case of gastroschisis, they're like, nope, just gonna stay on the outside.
Yeah, exactly. And so that happens in about 1 in 2,000 pregnancies. It's very rare. Just in general, it happens in 1 in 2,000 pregnancies. And with this study of baby aspirin, it was something like 3 in 2,000 pregnancies. So it wasn't a huge proportion. And it seemed spurious at the time. And now that we have the data from this other big aspirin study where there was no increased risk in any birth defect, I think that we could probably recommend an earlier start, but that's why the 12-week mark.
Right. And obviously we don't want to do more things to babies in the hospital. So having that literature and data and being critical about it is important. I love one of these questions that's in the chat because this gets into, of course, what I do as a neonatologist. So someone is also asking, and you talked about this a little bit in your slides, how to plan for future pregnancies when you've had preeclampsia, especially preeclampsia with severe features. So in this person's case, her baby was IUGR. And for people who may not know that term, intrauterine growth restriction is the term we use, or fetal growth restriction. And that is a pretty serious diagnosis in my patient population and has an impact on the health of the baby years and years and years later. So we, both OBs and MFMs and neonatologists, we worry a lot when preeclampsia also causes babies to stop growing well. She mentioned having severe postpartum preeclampsia in the second pregnancy. So now she's had 2 pregnancies, 2 significant complications. You know, how would this person go about talking to their physician if they want to have a third pregnancy and recognizing, like, how do I do this safely? How do I do this in a way that doesn't compromise my health or the health of that fetus, that baby?
That's a great question. And so for the audience, you mentioned 3 types of doctors. You mentioned the neonatologist, the OB doctor, and the MFM doctor. So I do the third. I'm an MFM, which is maternal fetal medicine or high-risk pregnancies. I would recommend that you get a preconceptional consult with your MFM doctor or a high-risk pregnancy doctor to talk through your options, because you are the type of patient we love to see, because we actually do have options and tests and different things that we can do. There's some blood work that needs to happen because it might be part of a larger syndrome when you have preeclampsia with severe features or early preeclampsia. So there's testing that we can do. We would still go ahead and recommend the baby aspirin, but there's some interventions that might be on top of that we could do if we found anything on some of your blood tests. We could also talk about interventions between pregnancies and ways to improve pregnancy outcome in general. One of the things that we don't talk about as much now that we used to maybe 20 years ago is pregnancy spacing. And so a lot of us are having pregnancies a little bit older. Certainly I was way over 35 when I had my kids, but if you can ideally space a pregnancy 2 years from the last pregnancy, that gives your body time to really heal, particularly if you've had a preterm birth. So that's a really important thing to think about as you're thinking of another pregnancy, because the sooner you have another pregnancy, you might continue to have some of these outcomes. But there's so many things that we can do, so many things that can be planned. And so I would recommend seeing a doc for a preconceptional consult.
So definitely being very proactive, sitting down and saying, I want to have the healthiest pregnancy I can have. I've dealt with this twice now. Doesn't mean you can't get pregnant again, but let's have it. I like it. I want to pause for a second because these have been fantastic questions from the people that are here with us. But I really want to go back and just remind people about what the symptoms are, because I will tell you one of the things I see is that when I talk to families, they just didn't recognize the symptoms of preeclampsia. So you talked about how it can happen suddenly. Like one day you're fine, and the next minute you wake up, you're swollen all over, you have the worst headache of your life, and you're seeing spots. And I think particularly, you're pregnant, you're tired, you don't feel well, sometimes you have a little swelling, we feel like we have to push through and take care of everything else. So one of the things I often see and worry about are either A, women dismiss their own symptoms, or B, they go to the doctor and their symptoms maybe aren't recognized for being as, like, the collection as severe as they could be. So can you just kind of remind us again, like, what those significant symptoms are? And for people who aren't pregnant, but you have friends that are pregnant, like, what should we be watching out for when our friend is pregnant? And when should we worry or tell that person, we should get you checked out just in case?
Yeah, those are great questions, and it's very important to go through these again. So a headache, and the caveat is a headache that doesn't go away with Tylenol. So people get headaches, and pregnant people get headaches, and actually the most challenging patients are the ones who chronically have headaches and who are migrainous, because now you're trying to discriminate if this is preeclampsia or not. But a preeclampsia headache is fairly typical, and it's not like other headaches. And in theory, it should go away with Tylenol, and sometimes that can be a sign that you're getting a much worse form of preeclampsia, because that might herald an eclamptic seizure. Most people with preeclampsia don't have symptoms. So if you have high blood pressure and a headache, that's where we really get concerned. So headache that doesn't go away with Tylenol, and then the spots or lights in your vision, and I'll give another caveat to that. So a lot of pregnant women have low blood pressure. And if you're laying down and get up suddenly with low blood pressure, you're going to see lights. That's not the lights that we're talking about for preeclampsia. What we're talking about is you're standing there, you haven't had a sudden move in position, and then you see floaters. So that's concerning. And then pain right here in the epigastrium, so right up here, right kind of over where your belly is, and deep in that area. Those are the three signs that we use for preeclampsia. There's other things that people talk about, the really bad swelling, all of that. If your girlfriend is pregnant and you see her one day and she looks normal to you, and the next day you can't recognize her because she's so swollen, that would be something to comment to her and maybe encourage her to get her blood pressure checked.
Right? Because a lot of times we think like, oh yeah, I'm pregnant, so I have swelling. And
Yeah.
you're right. You can't go by that alone. But I do feel like there's kind of, and even some of the scarier things like the pain, right?
Yeah.
To me, that seems to be one of those things like, check your blood pressure. Maybe something else is going on.
Yeah.
So,
Yeah.
Again, amazing group that we have here with us. The time is flying by. There's another great question in the chat, and you're like, oh my gosh, we're getting like straight pharmacology now. So, as a COX inhibitor, do you see early closure of the ductus arteriosus with prolonged aspirin? I love that question because it's what I do, but I don't think I've ever gotten that question in a webinar.
Yeah, no, it's a great question. It is a COX inhibitor, and that is specifically why we use low dose aspirin. So it's a great question. That's why we don't use a 325 milligram, because that inhibits, there's two forms of COX, and now I'm just geeking out. There's COX-1 and COX-2. And if you take a full dose of aspirin, you're going to inhibit both of those. So we don't want you to do 325. So that's too much. So that part we know. Anything less than 300 is considered a low dose of aspirin. And what the research is answering now is what is the best low dose. And we're working on personalized doses and all of those cool things. But the low dose of aspirin will only inhibit COX-2. And so you get the effect of, the preeclampsia pathway without concern for the ductus in the way that you would with a full aspirin or a Motrin or anything like that in the third trimester. So great question, but the baby aspirin will not affect that.
And for those of you who are like, where did they just go right now? And are they coming back? So the ductus arteriosus, why neonatologists and MFMs get along so well. It's an important structure that really helps the placenta take care of the baby before the fetus is is born. If it closes too early, it creates a lot of problems that we absolutely want to avoid. Most of us, once the fetus is born and the baby start crying and a whole bunch of other things happen, the duct starts to close and you never think about it and never worry about it. Unless you're born premature. But this is not my show, so I'm going to not talk about babies, but I hope you can understand, even in our conversation with each other, how much what we do is different, but how much we have to talk to each other in order to take care of the person who's pregnant, the fetus, and then afterwards, the baby that's born. There's another question that we had in here. A couple of questions that I want to try to go through, then I want to make sure I hit most of the questions that were submitted in advance. So this is more of a prenatal care. And I think it's important for people to understand exactly what's supposed to happen, particularly if they're worried about being high risk. So this person is 40 years old, first time pregnant, being seen by an MFM. So that's automatically a good thing. Right now is at 24 weeks. Going to the appointments, they're only doing ultrasounds. Is that what you would expect for the MFM experience at this point in the pregnancy?
So I would say that it's going to be incredibly variable because it matters whether you're being co-managed by an MFM and an OB provider, or if you're managed only by an MFM. If the MFM is providing all of your prenatal care, then whether it's an ultrasound or some acknowledgement of the fetal heartbeat will happen, your blood pressure will be measured, all of those types of things will happen if they're your primary obstetric provider. And it might be variable if you're only seeing them in consultation, but not for an OB visit. And so that's something that if you've been referred to MFM by an OB provider, then you might want to clarify who's taking the primary care of the pregnancy. And so it really does matter. It's very specific to each individual and each health system, the way that MFM providers work. Certainly, probably it's more common to have MFM as a consultant or in a consultation than as the primary doc, although here at UCSD, we do both the primary care for our patients and we do consulting.
Okay, so really it's important, like you said, to know who is driving the ship. Yes. And how they're talking to each other and making sure that they're talking to each other.
Yes.
Okay. So one other thing I'd like for you just to review for another question is for partners. How do partners support people that are dealing with preeclampsia in the pregnancy?
That's a great question. I think it's really helpful for the partner to know what the signs and symptoms are, support them, but also there's sometimes difficult decisions that need to be made. So the bread and butter preeclampsia that happens at term is usually something that we don't worry so much about. We deliver the baby is term, whether that's 37 weeks or 39 weeks, that it's better for mom and baby to be delivered. It's more challenging when we have to have conversations about preeclampsia and it's preterm. And so I think one of the important pieces that I should mention before we're done with this is really make sure that you feel that you have a good relationship with the person taking care of you. And if you don't, and if you notice that early on, try to change providers, because sometimes if you're going to have a conversation like this, you want to be able to trust them. And having your partner support you and also being able to trust and advocate for you is great. I always think of myself as the primary advocate for my patient, but having family, as an advocate too is important. So the trust factor with your provider is going to be really important. And then having your partner just support you and understand that sometimes we have to say pretty quickly, we think you might need to be delivered. And, having that trust with your provider and the support of your partner is really helpful. I think sometimes it becomes challenging when someone who maybe has less knowledge is driving you towards an area where you feel pretty certain that you're supposed to be going, but they're driving you in an opposite direction. So that can be challenging. So I think support and trust all around of the teams is great. And, the more people that you have supporting you, absolutely the better.
I would say I would add to that. Sometimes when you're dealing with preeclampsia, I mean, you're having headaches, you're having pain, like you don't feel good, and it's hard to
Yeah.
listen, absorb. And so having someone that can speak for you if you're not feeling your best and can kind of know the terminology, because I will tell you, just even how we reacted in this webinar, when you know a little bit of the lingo and actually not just know it, but understand it, you're like, oh, okay, like they're asking these questions. Let me make sure that I'm answering it. And so there are certain, I like to call them buzzwords or trigger words that were like, oh, we got to pay more attention. And so being able to say, no, listen, these are the symptoms she's been having, or this person's been having, this is why I'm concerned, as their support person, I think is really helpful as well. You can be a tremendous advocate for someone, especially when they're not feeling well and they're kind of more vulnerable. I think the other thing, and you started to touch on this, it can be very traumatizing because you can get really sick really fast, and you're going from, I was fine yesterday, and now you're rushing me off and cutting me open for a C-section. That's never an easy decision, and it is very traumatizing, but we're often weighing avoiding complications, avoiding those rare complications, and doing what's best. And like you said, having someone you trust so that you have a sense of, if this happens, we have to go to C-section. But our goal is to get you to 37 or 39 weeks. And I think that's a very different conversation than you walk in like, I don't feel well, I have a headache, and next thing you know, you're cut open.
Right, right.
That's two different things.
Yeah, particularly if it's someone that you've never met before, it becomes a little bit challenging in that scenario. Definitely.
Okay. Time went way faster than I wanted to go, and I'm going to get in trouble. There was one question I didn't get to ask, and I do apologize about that. But I'm supposed to also tell you about all the other amazing things. And thank you for being such a fantastic expert to kind of talk about the research, talk about what we know, and talk about what we don't know. I also want to thank all of you for being here. We can't see you, but I know this may sound strange. Your energy was incredible. Like I could feel, like I think someone wrote in the chat, like, yes, I'm taking notes. So the nerd in me appreciates you showing up and wanting to have knowledge that's powerful, that can help you, that can help the people you love, that can help even people you don't know. Because I think that's important to us, is that we want you to know how to take good care of yourself, how to advocate, and how to protect each other, how to love each other by showing up in these spaces and saying, we can change the outcome and we can really birth magic, which of course means a lot to us. Now, I do, yes, we will have recordings. They will be freely available at the end of all our sessions. I can't go through everything, but I will tell you we have an amazing week lined up. We want you to have a plan when it comes to preeclampsia, recognizing the symptoms, knowing how to be a support, understanding that once you've had preeclampsia, it does change things for you, and how to follow up with a doctor, even when you're no longer pregnant. But as we get into the rest of the week, we're going to go through a range of things. One of the things I'd love for you to attend, we have 2 sessions tomorrow. It's that little nudge to remind you about self-care. And part of self-care will lead into our second session that's happening a little bit later after you put the kids to bed. And this is a really important session about how to understand and recognize the chemicals in beauty products and what we should and shouldn't be exposing our bodies to. When we get into Thursday, we start to talk about some of those biases. We talked about how racism is a risk factor. How do we deal with that and recognize the truth, but don't become victims? And then going into the rest of the week, we get to have great conversations around providing human milk and breastfeeding, how to talk about those things that are uncomfortable. Remember, we told you, ask your family, what was it like when you were pregnant? And then we kind of end with what brought us together, and that's community. And how do we build a village from people all the way from Honolulu to Jersey? And then how do we work together and make connections to go back to the idea of, even in whatever space I'm in, I can be in control of my healing through the power of meditation and so many other things that go beyond what I do as a physician. And so the idea is to bring all these things together to empower you to be your best selves, to be more than magical, but to be marvelous. So thank you so much for being here this evening. We are so happy to have you. We hope to see you. Invite more people to come and share with us what you liked and what you'd like for us to talk more about in the future. Have a wonderful evening, everyone.
Thank you.